Hi everyone, and welcome to the IDFA and AusPIPS webinar on SCIg Access and Advocacy, the National Picture. Today's session is proudly co-hosted by AusPIPS and IDFA. Together we'll be exploring immunoglobulin therapy, what it is, how it works, and the different treatment options that are currently available. The webinar has been designed to support patients, carers, and our wider community in building a clear understanding of IG therapy. Our goal is to empower you with knowledge so you feel informed, confident, and ready to engage in meaningful discussions with your healthcare team about your treatment journey. Before we begin, I'd like to acknowledge the people of the Dharawal lands on which we are presenting from today and pay respects to their elders past, present, and emerging. We also extend our respect to any Aboriginal and Torres Strait Islander people who are joining us for this webinar. The webinar will be recorded and added to our website. Just information about the Immunodeficiency Foundation. We are a national organisation representing people with primary and secondary immune deficiency and have over 2,000 members. Our key priorities are education, awareness, building community, and driving change through advocacy. We hope that you enjoy this webinar and find it valuable. I'll now hand over to my colleague, Emily.
Thanks, Carolyn. So tonight's program brings together a range of perspectives on immunoglobulin therapy. Sorry for the dog in the background. We'll begin with myself. I'm Emily Edwards. I'm the Vice President of AusPIPS, and I'm also a researcher at Monash University in the space of primary immunodeficiencies. And I'll provide an overview of immunoglobulin treatment. We'll then hear from Rachel Dunn, Immunology Clinical Nurse Specialist and Chair of ASCI's Immunodeficiency SCIg for nurses, who will offer practical tips for managing SCIg therapy at home. This will be followed by Adam Friedrich, who's an IDFA adult member, who will give a personal perspective on SCIg and the impact on his daily life. And then to close, we'll have Elisa Kane, who's a health professional member and a member of the medical advisory panel for IDFA, who'll provide an update on IDFA's advocacy for SCIg. So AusPIPS, like IDFA, is a patient organisation that supports primary immunodeficiency patients and their carers to bring advocacy in the national perspective. So this includes interactions with key stakeholders, including government, which is both state, territory and Commonwealth, as well as pharmaceutical companies, clinicians and nurses. So I'll just pass back over to Carolyn.
Thank you, Emily. So I'd like to formally introduce Emily before she starts her presentation. Emily is a group leader of Primary Immunodeficiency Group in Monash University School of Translational Medicine. Her work uses functional genomics to uncover the molecular and cellular mechanisms driving inborn errors of immunity and their comorbidities. Emily's current focus is on the genetic and functional basis of predominantly antibody deficiency. She received the prestigious 2022 Grifols Aspire Award to develop standardized functional assays and new bioinformatic pipelines to advance personalized diagnosis. Emily is also the Vice President of AusPIPS, an Australian primary immunodeficiency patient support organisation, and a founding member of the Jeffrey Modell Diagnostic and Research Centre for Primary Immunodeficiency. Welcome, Emily, and thank you for being here.
Thank you, Carolyn. So thanks also for giving me the opportunity to speak a bit about immunoglobulin. So I'll just share that. Hopefully you can see that. So what we're going to talk a bit about what is immunoglobulin replacement product. So basically, immunoglobulins, or IG, which I'll be calling them during this presentation, which are also known as antibodies, are proteins that are produced after B cells, which are a component of our immune system, encounter antigens. And these antigens are for different pathogens, such as bacteria, viruses, and fungi. So the idea here is that these antibodies or immunoglobulins are a mechanism for us to be able to respond to a pathogenic insult. So the different colors you can see here are a different range of pathogens, and then you can see at the tip of this Y-shaped antibody structure is the antigen binding site, which binds that antigen portion from the pathogen, and that enables us to have what we call an antigen-specific response. So when these Igs bind to the antigens, they can then neutralize these bacteria and viruses for elimination from the immune system. So there are a number of different types or flavors of these different Igs, and they can be either surface bound on the surface of these B cells that produce them, or they can also be detected, they change during B cell development and maturation. So we have different types. So we've got an IgM, an IgA, an IgG, and an IgE. And so what we have is an IgA is found in mucosal areas such as the gut, and these are important for neutralization of different pathogens. We have IgD, which functions mainly as an antigen receptor or B cell receptor, which is on the surface of those B cells I told you about that produce these antibodies, predominantly on what we call naive cells that have not yet encountered the antigen. We have then got IgE, which is the least abundant and binds to allergens and plays a role in triggering the allergic response. And it's also important for defense against parasites. We then have IgG, which is the most abundant Ig, and this one's really important for what we call antibody-based immunity against invading pathogens, so particularly viruses, and is generated to vaccinations, so we call this systemic immunity. And it can also be used to coat pathogens so that they can be destroyed by other immune cells, such as phagocytes. And then finally, we also have IgM. So this particular Ig removes pathogens in the early stage of immune response, and we call this our primary defense. And it can also be important for stimulating a component of our immune system called the complement system in a process called agglutination. So these different flavors of antibodies are really important for making sure that we have a broad immune response to hopefully eliminate any invading pathogen that we see that we encounter in our lifetime. So the one that we will focus on today is that of IgG, and the reason for that is that IgG is the most abundant, and it's about 70 to 75% of the total Ig that we find in our blood. So that's the reason why there's a focus on replacing IgG in individuals who are antibody deficient or are deficient particularly in IgG. So there's a high abundance of this particular IgG in your system due to the production, and a lot more of it is produced. And it also has a longer half-life, so stays around for a lot longer than the other IgG subclasses or isotypes. Typically, its half-life is about 23 days, and this is why if you receive intravenous Ig or IVIG, you have a infusion every 2 to 3 weeks. And obviously, if you have subcutaneous, that timing is slightly different. This particular Ig is important for protecting against both bacterial and viral infections. And it's also, importantly, the only Ig that's transferred from a mother to fetus across the placenta. So it's the only one that provides passive immunity, which shows and supports the importance of this particular IgG and its replacement in patients with immunoglobulin deficiencies. So what about in the context of primary immunodeficiency? So I'm talking to everyone who already knows this, but of course, these are inherited disorders caused by genetic variants or chromosomal abnormalities. And the largest group of these patients are those that have antibody deficiencies or immunoglobulin deficiencies. So this is caused by either the absence or reduced number of B cells that produce these immunoglobulins and or a reduced production of immunoglobulins by the B cells. So you either have a reduced or absent number of the cells that produce these immunoglobulins, or these particular cells, the B cells, do not produce these immunoglobulins efficiently. As such, if the IgG is reduced in a patient, they may qualify for Ig replacement therapy. and the aim of which is to replace the missing IgG that is missing from the patient's immune system. And also to note, there are some patients with acquired immunodeficiencies, also known as secondary immunodeficiencies, who may also qualify for treatment, because some of the immunosuppressive treatments that we see for example, for transplants, also do cause antibody deficiency. So these patients can often be also supplemented with this therapy. But one thing to be really clear about, and I know that I'm sure that Rachel and Elisa will also allude to this in their presentations as well, is that there is criteria that exists to determine a patient's eligibility for treatment. And these are set out by the National Blood Authority. So there are a number of different clinical diseases that actually are qualify for immunoglobulin, but each one of those, within each of those diseases, has an eligibility checklist that needs to be adhered to make sure that the recipient qualifies for access to Ig therapy. So what is immunoglobulin replacement therapy, or IGRT as I call it? It's a cocktail of antibodies pulled from approximately 1,000 plasma donations. It's an IgG enriched product. And within this product, there are a number of what we call different IgG specificities. What this means is that the IgG molecules within this product are able to bind to a number of different pathogens. So these are reflective of the circulating pathogens within our community, but also the vaccine antigens that are encountered. So those IgGs can bind to those different pathogens and then basically neutralize the pathogen for removal. And the hope of actually reducing infectious burden of the patients and or reducing infection severity. So overall, the hope is there that you will reduce the incidence, the persistence, and the severity of infections. But one thing to note is, although this is called liquid gold, because of the color of the plasma, is not a magic bullet. It does not cure disease, but it is very much trying to alleviate symptomology and prevent infectious disease, but there will often be the need for additional treatments.
Our next speaker for this evening, and I would like to introduce Rachel Dunn. Rachel is an immunology clinical nurse specialist at the Perth Children's Hospital. Since 2008, Rachel has led the statewide SCIg program for the Perth Children's Hospital in immunology, service supporting children and families across Western Australia. In her role, Rachel coordinates care for children living with immunodeficiency as part of a dedicated multidisciplinary team, ensuring that patients receive comprehensive and compassionate support. Please join me in welcoming Rachel.
Thanks, Carolyn. Just sharing my screen. Okay. All right. Well, tonight I'll be going through some of the more practical strategies in regards to subcutaneous immunoglobulin. So it'll just be a brief overview. So I'll start with the sites that we use for administering SCIg. And basically, we're aiming to choose sites with high fatty tissue, and this generally tends to be the abdomen, the mid-outer thigh, upper buttocks, or the backs of the arms. And we generally recommend that you have at least 2 sites that you swap between regularly to allow those sites to adjust to the infusions. And certainly, you should always avoid broken skin. You can actually have more than one site running at a time, depending on the your tolerability of that, and also often of the age of the patient. Usually very young infants, we wouldn't do more than one at a time. But when you do run more than one set at a time, you just make sure that they're 5 centimetres apart. And so there's just a few pictures here of what it looks like to have SCIg running. And there are 2 ways that we administer SCIg. You can give it via a pump that's loaded with the syringe and the giving set with the needle going into the fatty tissue. And these pumps can be either mechanical or electric. And which pump you access really is down to your treating service and what they have available there. The other way it can be given is via push, and that's where you give it manually by hand and actually physically push the infusion through into the fatty tissue. You do need to have good coordination and good hand strength in order to do that. And the needle sizes are quite small. They usually go in at a 90-degree angle, and the length will vary depending on how much fatty tissue you have. and your size, and your treating team or your nurse would go through that with you and make sure they pick the right size for you. So some tips in terms of giving subcutaneous immunoglobulin to handle discomfort with needle insertion. Generally, it's tolerated quite well because the needles are very small. But for young children or for people who just feel uncomfortable with the needle, you can use a topical or local anaesthetic like a cream. MLAR is a commonly known one. You pop it on the site that you're going to choose 30 to 60 minutes prior. And then remove the cream, clean the site, and then you can use the needle and pop it in. That will numb the effect, the sensation of the needle going in. An alternative to this is you can apply ice 1 to 2 minutes prior to giving the infusion to numb the site before putting the needle in. And another important tip is when you're priming your line with the product, is try to avoid priming the needle, just going up all the way through the line just before you hit the needle. So that you don't have any of the product sort of going through the different layers of the skin, which can be irritating to the skin. And if you are using alcohol prior to inserting the needle to clean the area, just make sure it dries off first so it doesn't sting when the needle goes in. Another recommendation that often many treating teams will give is not to give your SCIg when you're unwell with a fever. Having a fever and being actively unwell with infection could increase the risk of reactions or the local site reactions while you're having the infusion. So often it's worthwhile delaying it for a couple of days once you've been treated by your team and started the appropriate medication or antibiotics as required, but discuss with your team if you're unwell. Another important tip to make the infusion more comfortable is to remove it from the fridge 30 to 60 minutes prior and bring it up to room temperature. That will just make it more comfortable while it's infusing. And often you'll be taught how to check the needle placement as well when you're popping the needle in, which just involves gently pulling back on the plunger of the syringe after you've popped the needle in. And that's really just to make sure it's in a good position and it hasn't hit a significant little blood vessel. So how much can you give? Anywhere from 5 to up to 30 mils at a site. And this is really dependent on the age of the person, how big they are, whether they're an infant, a toddler, primary schooler, adult. It will vary how much you can tolerate. And also the number of sites that can be used will vary between patients depending on their size. And their tolerability to having more than one needle at once. I mean, a lot of young children don't want more than one needle at once. So it's really patient specific, and you talk with your nurse about that. And how fast do you give it? Well, usually we will give it as per the product information that comes with the SCIg product. And then gradually with time, it will be given faster as the person can tolerate it. But it can always be slowed back down again as well to make sure that you're tolerating it and it's comfortable. So there's a lot of flexibility around how fast you give it. But generally, we want to give it within 2 to 4 hours once the needle is in, because there's no preservative in this product. And so we want to give it within a certain space of time. Generally speaking, pumps can administer them up to 30 mils per hour per site, depending on the type of pump you're using. When you're giving it manually by hand, you can actually get up to 1 mil every 1 to 2 minutes. But again, that's how you tolerate it. You can give it a lot slower than that. So there is a lot of flexibility around personal preference and working with your team. Local reactions are very common. You can get swelling, itchy, redness, induration, and sometimes a bit of discomfort at the site. It's usually short-lived and will reduce with time. But to reduce the discomfort associated with this, we do advise picking a couple of sites that you use and continuing to alternate between those sites or using those same sites. And the tissues in the area will adjust to the infusions, and what we anticipate is around the 8-week mark, you will start to notice a reduction in the amount of redness and swelling you're getting at the site. It's important not to scratch or rub at the site. You can also use a warm or a cool pack at the site to help reduce swelling or redness. And the other thing you can do is to reduce the infusion time. So if you've been giving it over 40 minutes, you may want to slow it down to an hour if it's getting uncomfortable and too swollen. Over-the-counter pain relief can also be used, like Panadol, Nurofen, or non-sedating antihistamines. It's important that they're non-sedating. And the other thing to consider is the needle length. Sometimes if the needle is too short, you can get an increase in the amount of swelling or redness or even leaking at the site. So if these things are happening, talk to your treating team and they can look at the needles that are being used as well. If you're getting excessive redness at the site or swelling or irritability, it's also worthwhile checking if you could be possibly reacting to the dressings or the adhesives that are being used to secure the needle in place. So always speak with your treating team and they can problem solve these with you. Some important tips about managing your SCIg product. Each product has different storage requirements, but generally we tell people to keep them in the fridge, and it's very important not to freeze them. When you're transporting your SCIg product from your collection point, you should have a fridge bag with you with an ice brick in it to keep it within that constant temperature, within that safe range. And when you store it, always keep it in its box that it came with and to protect it from light. Whenever you use your SCIg, make sure that it's within its expiry date, that the appearance looks translucent and there's no floating particles in it, and check the container integrity and that the lid on the vial hasn't come off or is ajar. It's important not to shake the vial because this can bubble up the solution, and once it's very bubbly, it's very hard to get rid of. The solution is fairly viscous, it's thick. And once you've drawn it up, give it immediately. So once you've drawn it into your syringe and it's set up to go, you can't put it back in your fridge and wait a couple of hours later to give it. Once it's drawn up, it has to be given straight away and completed within 2 to 4 hours. And this is again because of the lack of preservative in it. If you have any wasted product or there's a temperature breach, say you've left it out on a 40-degree day in the car, hopefully that would not happen, but if you've done something like that, it's important to contact your nurse specialist because there's things we need to do to ensure that you can get the next sort of immunoglobulin or subcut immunoglobulin in time. Other considerations for you to consider is make sure you keep a diary of your infusions. It's a way of recording whether or not you're having any issues with at the site with the infusion and whether things are improving over time or whether they get worse compared to before. And often now we will ask you to turn your SCIg diaries so we can keep a record of what you've been giving at home. It's also important to get a plan from your treating team, and this will outline who to contact for advice, your exact SCIg regimen, how much to give and where and how frequently, and also where you collect your SCIg, your immunoglobulin product from, where you get your equipment from. And just be aware that you're only allowed to collect a maximum amount of 2 months supply of SCIg at a time. Another thing to be important thing to look out for is how do you return your sharps? You'll be given a sharps container to put all your sharps in, including the used vials of the immunoglobulin product, and you need to be aware about where to return them. Sometimes your hospital will return them, or they could be your local chemist will take it. But each state has different areas where you can drop off sharp containers. And there is a site that you can go to on the NBA, that the National Blood Authority, that can go through state by state where you can return sharps containers. It's really important to plan ahead for travel. So if you're traveling, please let your team know as soon as possible. There are permits that need to be arranged through the Therapeutic Goods Association before you can take SCIg overseas. So please let them know. Letters will need to be arranged so you can take your sharps and pump with you on board, and letters so that you have somewhere, letters to give to someone if you have to present to hospital while you're overseas. You've also got to make sure you're meeting the temperature requirements for the product when you're traveling on the plane. If you're going camping, again, only take what you need. Make sure that it can be kept within the safe temperature range, and talk to your treating team for advice around this. Sometimes you may want a dose of the intravenous immunoglobulin before extended travel to save taking SCIg with you, so talk to your team. So just some resources there that you can access. ASCIA has some SCIg resources, AusPIPS and IDFA do as well, and the National Blood Authority and Lifeblood also have information on SCIg there. And just to make you aware that in the future we'll be doing a more in-depth version of practical tips for managing SCIg therapy at home. So that's me done, and I'm going to head back to Carolyn. Thanks, Carolyn.
Thank you so much, Rachel. That's really important to provide those practical tips. That was really useful. And just for anyone who is on the webinar, we will be recording an IDFA deep dive series with Rachel where she'll go into much more detail about those practical tips. So keep an eye out for that in coming months. Our next speaker is well known to many of us in the community, and I would like to introduce Adam Friedrich. Adam brings almost 30 years of experience in the not-for-profit sector and has served on the boards of numerous organisations. He's a highly respected patient representative, contributing his expertise to Commonwealth Government health committees and working groups. Adam is deeply committed to advocating for health consumers, ensuring their voices are heard and represented effectively. Living with a primary immunodeficiency, CVID, he is especially passionate about helping people with immune deficiencies along with their carers and their families. Please join me in welcoming Adam tonight.
Thanks, Carolyn. Pleasure to talk to you all tonight. As you heard, I was diagnosed with a primary immune deficiency, common variable immune deficiency. That happened to me when I was in my late teens. If you look at me now, you can tell it's been quite a while since I've been in my late teens. It was more than 30 years ago. And in that 30-year period, I've been treated with immune replacement therapy with a combination of intravenous and subcutaneous. I think over that time, I was just working out before, I've used Intragam, Intragam P, Gamma Norm, Hizentra, and Hizentra AU. So a few different products there. I was one of the early adopters of subcutaneous immunoglobulin or SCIg in Canberra when they did their first rollout. So I've been using it for just over 10 years now. And for me, my immunologist at the time told me that the autoimmune complications that I get around my immune condition mean that SCIg would keep me more stable and give me less autoimmune responses. My levels don't go up and down as much, so it should help me to feel better overall. And I think his advice on that was right. My sense over the past 10 years is that I have been more stable in the move to SCIg. A lot of what Rachel talked through before resonated and made sense to me. I do 2 treatments a week using 2 sites. I do manual push, and I do manage somewhere between the 1 and 2 mils a minute on manual push. It's an amazing difference. For me, the manual push means that I can do it whatever my body copes with. Sometimes I sit down, I usually do mine at night, I sit down to watch television, sort of get started on something, go, oh, I've finished already. Other times I get started, I watch the entire show, look down and go, God, I've still got a lot of this left to go. So just seems to depend on exactly whether I hit the magic spot for it to flow in smoothly or whether it hurts and goes more slowly. Rachel talked about pulling back a bit to see if you get any blood or anything. I do that all the time, but my experience has shown that if I put it in and I hit a vein or something unusual, I can always tell just about instantly. I don't really need to, I'll pull back and wait for the blood to come, but I'll know that it's different to normal, it'll feel different. And I think that's something, if you're doing it twice a week for 10 years, that's an awful lot of experiences to build up and get a sense of what works. I also find the tip Rachel said about leaving that very small air gap at the top so that you haven't got any immunoglobulin contacting your skin when you're trying to stick it in really helps as well. I do use the same sites. Well, 2 different sites I use because I'm doing it twice a week. One on top that I do one time and one lower down that I do another time. And the reactions Rachel talked about, the only thing I've ever reacted to is a type of tape that I've been given to hold the site together. There's 2 different types of tape that Canberra Hospital uses. One of them is fine for me, and one of them I come out in a red rash the day afterwards where I've used the tape. So I've worked out to avoid the type of tape. Rachel also talked about keeping a diary of your treatments. I find that a really useful way to keep a track of my symptoms as well. So when I go in to see my immunologist, I can talk about saying, well, look, looking back, this is the symptoms I've been having on these dates. I suppose talking through the process of what it's like using subcutaneous immunoglobulin, it gives me a lot more flexibility and freedom than I feel I had when I was using intravenous immunoglobulin. But it does come with something of a cognitive load in managing the treatment as well, because it's me managing the treatment rather than the hospital managing it for me. Some of the advantages for me, it doesn't intrude on my work time as much. I used to have to take a half a day of leave to go and do my treatment whenever it was due. Now I tend to do it at night after I've had dinner, sit down and watch some television while I'm doing it. And it has less, it still takes up time, but less impact on the rest of my life. I find with the shift from intravenous to subcutaneous, I feel less washed out after treatment. I also find my energy levels generally stay more consistent. People talk about immunoglobulin giving them energy and feeling a bit like an Energizer bunny after a treatment. I definitely used to be like that when I was on intravenous. The day after my treatment, I'd be full of beans. The couple of days leading up to the next one, I'd be very slow and lethargic. That smooths out for me with subcutaneous. Subcutaneous also makes travel very easy for me. I do a bit of international travel for work, which is usually short, sharp trips. So I tend to load myself before and after and not travel overseas with it, but can then travel for a week or so and do treatments either side of the travel. I can also do treatments everywhere around Australia. In July, I did treatments in Central Australia. A couple of years ago, I did treatments in Far North Queensland. I have photos of me set up to do treatments next to my tent. It is a challenge to keep your aseptic environment when you're camping in a tent. And it's a challenge to keep it cool enough in an esky and so on, but it's possible. I would say subcutaneous for me is not an absolutely perfect process. I don't always want to do it. It gets to the end of the day when it's a treatment day and I say, I really don't want to do this tonight. And particularly, I don't want to do it when I'm feeling unwell, when I'm feeling tired or run down or sick, which is when I probably need to do it most, is the time when I feel least like doing it. I am very good at making myself do it, but I often find it takes me half an hour to an hour of finding every other job I could possibly do around the house before someone says, are you going to go and damn well do your treatment? That will sort of settle me down and start me. But I think for me, subcutaneous is better than the alternatives because of some of those side effects I used to have on intravenous. Probably the last thing I wanted to touch on was a little bit around challenges and barriers. And I think for me, the challenges and the barriers are offset by those advantages of the extra freedom, flexibility, and reduced side effects. The biggest challenges for me, one of them is actually the loss of access to my immunologist. When I used to go in for intravenous treatment, my doctor would usually wander through, maybe not every time I was in there, but probably every second time. So I would have a chance to chat about anything that came up along the way. That sort of incidental contact with doctors doesn't happen as much when you're treating yourself at home. So I guess I've had to become part of that cognitive load is becoming more proactive in working out when I actually need to reach out to my doctor and say, I'm not due to see you yet, but I've got something I need to talk to you about. One of the other challenges for me was around pumps. And I think I was lucky enough to take part in a study in the early stages of my subcutaneous where I spent 6 months using a pump and then 6 months manual pushing. And then at the end of the study, I talked about what I liked and what I didn't like. And at the end of the study, when the hospital offered me back a pump, I said, actually, I've decided I really like the manual push. It doesn't hurt anywhere near as much because I just changed the speed depending on what works. So I guess for me, pumps were a challenge, but I got rid of them and that solved the problem for me. Although manual push is not for everyone. And the last challenge, somewhat bizarrely, is what to do with sharp bins when I'm traveling. I think that's gradually improving. But 10 years ago, when I first started doing it, we'd go on a family holiday. I'd take small sharp bins with me that I'd be using and fill up. And then I'd try and take them to a hospital and drop them off. And it would take me 1 to 2 hours to manage to persuade someone in a hospital to take my sharp bin and let me leave it with them. When I'm doing treatment at home in Canberra, it's very easy. I take it in and I give it to the SCIg nurse when I get my new products. But when I'm traveling, it can still be problematic trying to explain yourself at different places around a hospital of why you've got a sharp bin and why you want them to take it. Get there in the end, but it does sort of make things a little bit more challenging along the way. And I think now I tend to take the sharp bins with me, fill them up while I'm away, bring them back and give them to the immunology nurse in Canberra after the holiday. Works it more easily for me. I think that's all I wanted to talk about there, except to say that I think SCIg is really a great option for people. Doesn't work for everyone, but something to think about. If you're already using it, you know that. If you're not already using it, maybe worth giving it a try and seeing if it works or not. Thanks. And I think, am I handing back to Carolyn again? Thank you.
Thank you so much, Adam, for your insightful stories around the use of SCIg. I think that's really important for our members, particularly people who may be considering what their best treatment option is. We'll now move on to our final speaker for tonight. So I'd like to introduce Dr. Alyssa Kane, who is a clinical immunologist and immunopathologist at St. Vincent's and Liverpool Hospitals. Alyssa's clinical and research specialities are in the diagnosis and management of primary immunodeficiency. She has established an adult immunodeficiency bone marrow transplantation service at St. Vincent Hospital and is actively involved in translational research, investigating mechanisms of disease and improving clinical outcomes in people with primary immunodeficiency. Welcome, Alyssa.
Thanks, Carolyn. So thank you for inviting me to speak today. And I think today, it's been a really good seminar, and I've learned a lot as well from listening to my colleagues speak. I think some of the things that I wanted to cover, firstly, from a clinical point of view. So I prescribe SCIg and immunoglobulin replacement therapy to my patients. My practice is to always give patients an option of whether they want to go intravenous or SCIg. And I think what hasn't been said is that we're very flexible. So the studies have shown that the reduction in infections is equivalent for both products. So we don't mind which product people use. And so some people might find one product better than the other, and it may be for a variety of reasons, including the ones that Adam's covered. And we know that people's lifestyles change and their circumstances change, and that cognitive load's a real thing. Sometimes people just need a bit of a break, so they'll come back and say, oh, actually I want to do infusions for a few months, and we're very happy to organise that. So I think that's one thing to keep in mind in terms of self-advocacy. Have a chat to your doctor, have a chat to your nurse, because we're very happy to accommodate those changes. I have patients who sort of flip-flop all the time, and that's totally fine. In terms of where we're at with advocacy, SCIg is becoming more and more the preferred product because it is easier on lifestyle. Travel is definitely easier because you can take it with you even overseas, and you could administer it yourself. If you go the intravenous route, we do try and find a hospital where you can have it done, but there may be issues with insurance or costs involved. So there is a lot of advantages of using SCIg in that situation. In the transition over from predominantly intravenously administered immunoglobulin replacement to predominantly subcutaneously administered immunoglobulin, we have in IDFA realised that the consumers are facing some issues with access to the product itself or access to the consumables. So in terms of what information that we would like, together with AusPIPS, IDFA and AusPIPS are going to run a survey, a consumer survey, to understand what the challenges have been in going to SCIg. From a funding point of view, the federal government has provided funding for SCIg, and so there should be funding coming to at least the public hospitals for that treatment. And so we're hoping that then that filters down to making sure that everybody has access to SCIg and the consumables as well. But we know that access is different according to which site that you're accessing it from. So that's the sort of information that we would love to hear from you, so we can think of ways to make sure that the access to SCIg is fair and equitable. I think that was mainly what I wanted to cover today. Are we doing questions, or am I handing back over to you, Carolyn?
Thank you, Alyssa. And I'd like to thank all of our speakers tonight. I think it's been a really great combination of expertise from a research perspective, practical perspective, patients, and obviously manufacturing from CSL. So just before we finish up the webinar tonight, there's just a couple of things that we'd like to highlight to our audience. And they are that there's a range of resources available around SCIg and other treatment options on the IDFA website. AusPIPS also have a fantastic brochure around immunoglobulin that looks at the difference between SCIg and IVIG. So I'd recommend both of those resources to you. We do have a couple of events coming up. If you are one of our members in Melbourne, we've got a coffee club, which is an informal get-together being held in Melbourne on the 8th of November from 10 to 12. So please get in touch with us if you would like to attend that. This week is International Plasma Awareness Week across Australia, and hopefully you've heard some media around this. So we have partnered with Lifeblood, and this week we have a range of plasma parties occurring, which is where we go into Lifeblood donation centres, and we have a member who comes with us and talks to the donors and thanks them for their valuable contribution in terms of plasma, which is then made into the immunoglobulin products that treats our members. If you are a member who would like to support other members, please have a look at our Circle of Support program, which is a peer mentoring program where we train more experienced members to be a mentor for people who might have just entered onto their health journey. In terms of upcoming webinars, we have our next webinar on Thursday, the 4th of December, and it's around understanding genetics, carrier screening, and targeted support. So please join us for our final webinar of the year. That I'd just like to really thank Emily from AusPIPS and the great working relationship that we have with AusPIPS around presenting these important webinars which benefit anyone with an immunodeficiency. I'd also like to thank Rachel for her practical tips tonight, Adam for sharing his story around being a member and a patient with an immunodeficiency. Alyssa, thank you for joining us as a health professional with your clinical insights. I'd also like to thank my colleague Crystal for her fantastic organisation tonight. And of course, we would like to thank you as our audience. There will be a recorded version of this webinar that will be sent out to all registrants in the next couple of days, and it will be made available on our website. So I'd like to wish everyone a good night and thank you again to both our speakers and presenters.